Welcome to the U.S. Healthcare System Lecture Series by Monika Wahi, based on Essentials of the U.S. Healthcare System by Shi and Singh. Chapter 7, Outpatient Services and Primary Care.
Welcome to Chapter 7, Outpatient Services and Primary Care. There's probably a lot more to outpatient services and primary care than you realized. Primary care is very important now in our U.S. healthcare system. It always has been important, but now we really need it. So pay a lot of attention about what you should be getting from your primary care practitioner.
Chapter 7, Outpatient Services and Primary Care. Learning Objectives. At the end of this lecture, the student should be able to give an example of a health outcome which is improved in a population with good access to primary care, name and describe one of the domains of primary care, describe one outpatient setting, and in that setting, one way primary care can be delivered, and name one subpopulation in the United States which currently has reduced access to primary care, and say why. So, all this talk about primary care, what is primary care? In the past, I have always equated primary care with outpatient care, but that's not exactly correct. So let's look at first at what outpatient care is. I like that they use the term ambulatory because that literally means walking. But if you think about it, when you're really sick and you go to outpatient care, you can usually barely walk. In fact, some people don't even walk it. So the fact that they call that ambulatory, I think is the hugest joke in the world. But anyway, that's what is meant by outpatient care, which is any healthcare services that do not require an overnight stay in an institution of healthcare delivery. So if you can find a way to crawl over the threshold of an outpatient setting and then get care and crawl home, that's ambulatory or outpatient. If you don't manage to crawl home and you get admitted, then that's inpatient care. So what is primary care? Well, that's not as easy to explain. So a lot of people come up with these definitions, organizations come up with these definitions, and they try to nail down what is primary care. I'm actually going to start on the right side of the slide because this is more of an American definition by the Institute of Medicine's Committee on the Future of Primary Care. They said that it's whatever it is, it's preferred but not the only route of entry into the healthcare system. I think the reason they said that is because if you've ever tried to go to primary care for some help, sometimes you have to wait a long time because, as you'll see, there are shortages of primary care doctors in the U.S. So sometimes you show up in specialty care and you end up in the healthcare system. And so the Institute of Medicine just says it's preferred but can't really make you do it. Because the provision of integrated accessible healthcare services by clinicians who are accountable for addressing a majority of personal health needs, developing a sustained partnership with patients, and practicing in the context of the family and the community. If you're going to try and do that, you can't be a specialist, okay? You have to be a primary care practitioner. You have to keep seeing the same people over and over. So that's how the Institute of Medicine focused their definition. Whereas the World Health Organization, if you see that little globe there, they have to be more careful about their definitions because it has to apply to the whole world, not just the United States. So they threw in primary health care, not just primary care. And they say essential health care that is based on practical, scientifically sound, and socially acceptable methods and technology. And you'll see that term essential health care, which we'll get into a little later. And this has to be accessible to a community in an acceptable way. The cost is fair for the individual and the country, and the first level contact between the individuals and the healthcare system. Notice they really emphasize in the world that it's the first level contact. Like it's not preferred, it is. And so as you go through the rest of this lecture, think about why the world might feel differently than America and why it might be socially unacceptable in America to say certain things that is socially acceptable for the world and vice versa. Now let's get into something that's a little bit easier to define, which is levels of care. It's hard for us to maybe draw a line around primary care, but it's easy to tell primary care from secondary or tertiary care. So primary care has to do with a lot of things: prevention, diagnostic, therapeutic services, health education, minor surgeries. Primary care is an approach to providing health care, and so most of what happens in healthcare should be happening in primary care. However, every once in a while, primary care cannot handle what you have because you have something very special. In this case, secondary care is called in. This is short term. It's like a sporadic consultation with a specialist for advanced interventions not available in primary care. So, for example, let's say that you have migraines and they are controlled in primary care, but they start to get very bad, and your primary care doc really doesn't know what to do. Your primary care doc might refer you to a migraine specialist, and you would meet with him or her maybe just a few times, because then primary care can go and take over that from there on and manage your migraines. Tertiary care is for conditions that are relatively uncommon. So as you can see, primary care is mostly what happens. Secondary care happens from time to time, but tertiary care isn't supposed to happen that often. And that they tend to be, tertiary care is institution-based, highly specialized. So we're talking about like open heart surgery, or treatments for very unusual cancers or unusual genetic disorders. And so tertiary care, most people don't go through a lot of that in their lives, thank goodness. Unfortunately, those who have these unusual situations, they get stuck a lot in tertiary care, but that's luckily not that many people. Again, we're focusing back on primary care, so let's look at the domains of primary care. Even though the WHO and the IOM definitions don't totally agree, they overlap in certain domains of primary care. So I'm going to read these off and then we're going to go over them. First is point of entry. Next is coordination of care. Then you've got essential care. Remember I said we were going to talk about that. Integrated care. And finally accountability. So let's start with point of entry. If you can see on there, there is the ideal and then the current reality. And it's almost more revealing to read the ideal, because if you're trying to access healthcare in the United States and you've been having trouble getting into your primary care doc or getting one, or just even getting established on insurance because they require a primary care doc, then you will see that this ideal looks a lot different from probably what you're experiencing, which is ideally the minute you call primary care, they respond. They're the first contact and gatekeeping, and they're right there and they can get you in. Because they protect patients from unnecessary procedures and overtreatment. So let's say you have increasingly bad migraines, you keep trying to get in, you can't. I mean, your head hurts every day. You might just run over to the migraine specialist. Maybe that's not such a good idea. Maybe they're, if you have diabetes too, maybe what the migraine specialist says for you to do would contradict your diabetes care. So primary care ideally is community based, it's widely available everywhere, it's routine and expensive, and there's appropriate technology. When I think of the times I've seen people under the care of a mental health practitioner, they can call that person, make emergency appointments, talk to them on the phone, have them refer them for emergency care, and it's really pretty easy to connect with your mental health therapist. Yet, if you're having terrible migraines and you're just trying to call your primary care practitioner and saying, look, today I have a really bad migraine, what do I do? You're either going to end up in the ER or you're going to fight your way into a specialist. You just can't do this. And that is bad, because the whole point of primary care is to be cheaper and refer on for these expensive procedures. So when you read that and you realize this is what's envisioned, then you start to realize, oh, the U.S. healthcare system's not at that point yet. And we as patients might be going around this gate of primary care simply because we can't get in through the gate. So the gatekeeping is not working right now because there's not enough PCPs. And then the lack of the PCPs causes the system to malfunction. And then we as patients feel like we're just not getting treatment. And that makes us go around our PCPs and go to the ER and do other things to get unnecessary treatment sometimes, because people are off the beaten path. They don't know what you have. They're specialists and they're not generalists, and they aren't putting the pieces together properly, and it's not their fault. So primary care is just not widely available and may be very costly, and because of that, unfortunately, the current reality is not meeting the ideal. Remember, the next domain of primary care was the coordination of care. So if already people are going around PCPs to specialists in the ER and stuff because they can't get that through that first gate, then how are these people who are supposed to be coordinating that care? They may not even know you went to the ER or know you went to a specialist, so how can they do that? PC clinicians are advisors and advocates. They're supposed to refer you to specialty care and keep you back from it if it's not really needed. They give you advice on diagnoses and therapies. They're supposed to be able to sit down and discuss with you the treatment options, continuing care, what it's going to look like for your chronic conditions. Even if you're diagnosed today with something, maybe in 20 years that's going to have this effect on you if you don't do something now. Continuity, comprehensiveness, that's what you're supposed to get out of the coordination of primary care with your PCP. But of course, if there are holes in the system and you can't get to your PCP, this isn't going to work so well. So let's look more at the coordination role for primary care. So imagine you come into primary care and you actually don't have something that's very routine. It's whatever you're having that's being treated in primary care is not being obvious. Your primary care practitioner can send you for advanced diagnostic services. They're very good with the diagnoses because they have to know what you have if they're going to refer you to a specialist. They have to know which specialist. So sometimes it's not obvious. Like for instance, I have a vomiting problem and a lot of people thought, well, that's a gastroenterologist, but it turns out it's based on a neurologic problem, and so the right specialist is not obvious sometimes. And so diagnostic services, advanced diagnostic services, even in primary care, are usually used to get you there. If these diagnostic services show that you actually need surgery, then primary care helps coordinate not only with the specialist that may have helped with that decision, but also with the surgeons that are going to do the surgery. And also, if you do get admitted to the hospital for surgery or for other reasons, the primary care doc can help coordinate the inpatient care. So what happens then is you end up with continuity and comprehensiveness, because you've got that same person in the green circle in the middle, sort of air traffic controlling everything else. That person is able to make sure you get everything you need, and they know you. So if you had a surgery a few years ago, they still know that, right? And they think about that when you're going for your next surgery, for example. And this is the way it is supposed to work. However, in what situations might this not work very well? And we can all look at where all the moving parts are. There's a reason why that wheel moves around, is because there are a lot of moving parts. What if there's not enough green circles? How do you get to the other circles, right? You might just go in to get to the brown circle, the inpatient care, through the ER, with avoiding the primary care if it's not available. Okay, what if the diagnostic services are not available? What if the surgery is not available? Probably the specialist will be available because we have an oversupply of specialists in the US, right? And so that's not going to be a problem, but actually coordinating all of that is going to be a problem. So an example is this person who's written about in this case study, who happens to be me, got a drug as in preparation for surgery that had psychiatric side effects. And so primary care had sent me to surgery, and surgery gave me this drug, and then I had psychiatric side effects. Well, I called the surgeon. I didn't know. Obviously I was having psychiatric side effects. I couldn't even think. So I called the surgeon and I said, I don't know what's wrong with me. And the surgeon told me to call the psychiatrist, right? Okay, well, that's not really supposed to happen. The surgeon should have told me to call my primary care doc. My primary care doc should have told me to call the psychiatrist, because it took a while before my primary care people even realized that I was on this other psych drug now to deal with the surgery drug. Okay? So even though primary care was available to me, I was just dumb, I guess, and called the wrong person. And it's so easy to be just dumb and do the wrong thing in the healthcare system, even if you're in it. So if you can find a way to get primary care working in your country, which apparently we have a lot of trouble with in the US, it will really help. So countries with a primary care orientation just simply have better health levels, higher satisfaction with health services, and lower expenditures overall. So if you're looking behind the scenes and trying to figure out, well, why do we pay the most in the U.S. per capita for healthcare? Not everybody gets it. Not everybody even has health insurance, and we don't really have the best life expectancy and infant mortality rates and all that. Like, what is going on to cause that? Well, I think part of it is we don't really have a primary care orientation because we have too many specialists and not enough primary care. And so, of course, we're not going to be as healthy, and we're not going to like our health services as much, and we're going to pay through the nose for it. So as it shows on the slide, weak primary care infrastructures are associated with poorer health and higher costs. Well, might that be a clue? In the United States, states with higher PCP to patient ratio have better health. Lower hospitalization for PC issues. Makes sense. If you can get in with your primary care doc, you might not go to the ER. So adults with PCPs as their main go-to for health care have lower death rates and incur lower costs. So yeah, this affects your life expectancy. And it's closely linked with specialty care. The appropriateness of the interventions and the outcomes are better with the specialists when referred by primary care versus self-referral, right? Because if I think I have a gastrointestinal problem and I go there and it's not even right, do you think those people are going to figure out to send me to the neurologist? Probably not. They're not primary care docs. They're good at gastro. They'll probably do a million things to my gastro system. Whether or not it's needed is unclear. Now we get on to essential care, which I particularly like being from the public health sector. Primary care includes this component, this domain, called essential care, meaning not only does the primary care that's happening in the doctor's office or the nurse's office or whoever's office at the healthcare setting with you or whoever the patient is, it not only helps you, but it leads the optimization of not just your health, but the population's health, okay? So imagine, we can just drug you up in a clinic. Is that going to help the population? No. We need to look at your whole well-being and raise your well-being, because that's how all the ships will get raised in this ocean of public health. It requires the minimization of disparities. So if you have people who are racial minorities who are not getting health care, or they're getting crappy health care that's not affecting the essential care, that's not moving the needle of their population, that's a disparity, and we need to look at that. Money talks. Financing is the key element to healthcare, and without national financing in the U.S., it's pretty difficult to work out this essential care. If so many people don't have insurance, how do we make sure that their individual health is contributing to the optimization of population health? You can't. This mixture of private and public financing in the U.S. Is fragmented, so to keep with the whole boat thing, it's hard to steer this ocean liner. We're trying to do so with things like Healthy People 2020, but that requires everybody to just step up to the plate. Have you ever worked somewhere where there's this common refrigerator and everybody's just supposed to take turns cleaning it? That shows you how much stuff gets done in the U.S. healthcare system. If people are just expected to step up to the plate, how many times has that refrigerator smelled bad? And what does that smell like? It smells familiar, right? With this U.S. healthcare system and all of this ugly, smelly money we're spending on things that are not health. The primary care model, embraced by MCOs, but has this current role limiting to this low-cost general medicine and gatekeeping, right? So managed care organizations, they know what's going on. They know the same thing we do, that primary care is really good for them. It's good business. But they only have the clinicians they can work with as well. If they don't have that many general practitioners and they aren't going to pay them that much, then they aren't going to have that many on your health plan. And so now you're basically just standing in line to see them so that you can get to specialists. So right now, people don't really like it because it's controlling access to the rest of the healthcare system, and you have to stand in line a long time. Hence, we try to go around. Now let's get to the next domain, which is integrated care. So let's think about integrating care in three ways: having it be comprehensive, coordinated, and continuous. So what does that actually mean? Well, comprehensive addresses any health problem, any stage of a patient's life cycle. And remember, a health problem is sort of a big concept, okay? If you are worried about something, you may have a health problem, okay? If you are preparing for like a wedding, you're going to get married, maybe that can cause health problems, stress, maybe you're running around more than usual and you're getting exhausted. There's just so many different things that can cause health problems. And if you just sit down and look at like pathogens, germs, things like that, you're going to miss that whole comprehensive thing of a person's whole health. And so primary care is supposed to really look at all that. You can't really expect the surgeon who's going in and maybe removing a tumor to be the person dealing with that. That's a specialist. And also even a mental health practitioner who can really help you, they can't do much about your tumor. So primary care seeks to try and be comprehensive because it's got access to all these secondary care and tertiary care. They can hook you up, but their goal is to try and air traffic control around you. You're taking care of any health problem, whether you're a little kid or a teenager, whether you're in the middle of your life or towards the end of your life, you're older. That should be there, okay? And then on top of that, it should be coordinated. How many times have you found, especially an elder, taking two of almost the same drug? Maybe it's like a benzodiazepine and they're taking both Xanax and Klonopin. Okay? That's not very coordinated, right? You'll probably see that the Xanax was prescribed by Dr. A and the Klonopin by Dr. B, right? That poor person's probably knocked out if you know how benzodiazepines work. I actually saw this happen to a lot of elders when I was living in Florida. And so the provision of healthcare services needs to be optimal to meet the patient needs. Obviously, drugging up these people wasn't meeting their needs, and probably the reason was happening is that their care was not coordinated. They were probably visiting diabetologists and visiting mental health practitioners or neurologists, cardiovascular specialists, because as you get older, you might have more problems, right? And so if all these people are prescribing drugs and putting you on programs and stuff and they don't know about each other, they could actually screw you up, right? Finally, it has to be continuous. Care provided over long term by a single provider or team. The image I just described to you about the elder who may have multiple health problems, see multiple specialists. Well, let's just make this a little harder by making that elder be part of a special population that doesn't get the continuity of care right now, because he or she just isn't, maybe he or she is 64 and doesn't have Medicare, or maybe he or she is over 65 and literally cannot pay for what you have to pay for in Medicare. Remember, it's not free. People have to pay out of pocket, right? Remember the donut hole? And so let's say you're one of those people. Are you going to get continuous care? You probably aren't going to get care. So the IOM, Institute of Medicine, remember the American thing, they really stress in their definition accessibility and accountability. Remember what I just said about the elder on Medicare who may not be able to even pay for it? That's an issue of accessibility. And when I talk about the situation where the elder's on multiple different benzodiazepines because nobody knows what's going on, that's provider accountability. How can the elder be accountable for that, right? They're just doing what they've been told. And so the IOM is sort of jaded towards America, saying this is maybe where we need to work on primary care, is in the accessibility and the accountability arenas. So let's talk more about that accountability. That's one of our domains, okay? Let's start with the IOM's definition, again, very customized to America. Both patients and primary care practitioners have accountability. It's not just the physician or nurse's job, right? But it may not be equal, as you can see on the seesaw to the right. It's probably more accountability is held by the primary care practitioner, right? And remember, this balance of accountability will change over time, but it's that little triangle there, that fulcrum, that is based on mutual trust, respect, and responsibility. If the patient's being a deadbeat, not following up with their care, etc., then they are not being accountable. However, the PCP also has to be accountable too. So let's start with patient accountability. The IOM basically says that the patient should only use healthcare when needed and be responsible for their own health. That looks very simple. However, if you're a patient, you may not know when healthcare is needed. I can't tell you how many times I waver between whether or not we should take a serious issue going on in my family to the ER or not. And it is very hard to get guidance. Almost any nurse line you will call will tell you to go to the ER because they can't evaluate you. It's not that easy. You can't get on Skype with the nurse that easily and have them actually interview the patient or look at maybe the color of snot or whatever is coming out of their nose, And so if you call the nurse line, you're going to end up at the ER. So I don't know when healthcare is needed. And being responsible for my own health, half the time I go and I get contradictory advice from these different caregivers. So, and sometimes I'm told to do so many things I can't pay for and I don't have time to do. So there's some challenge in holding the patient accountable for their own health, even if it seems reasonable. If you look on the right side of the slide, there's also some challenge in holding PCPs accountable. Um, what what do you do if you go to your PCP over and over for a problem and they don't fix it? And later you realize they should have referred you to a specialist. You have advanced cancer. What do you do? What's your recourse? Where did it say that they were supposed to do this, and how can you show that they broke the law, so to speak? The PCP is supposed to manage all types of concerns. How many times have you gone to your primary care doc, made a list of 5 things that are wrong, and they just perseverate on one that they know how to fix? Okay, that's not going to do it. And so the PCP may have the knowledge and the skills. It's pretty easy to show that. They've been to years of college, and they have certifications, and they have licenses. That it's pretty easy to show that they're accountable there. But how are you going to hold them accountable for these other things? I'll bet you anything, it's not happening right now, and we're not calling them out. So what is outpatient care? We just went over what primary care is, and it's not the same as outpatient care. So now let's look at what outpatient care is. Let's just again revisit the differences between primary care and outpatient care. Primary care is just kind of like this philosophical approach. This is how things are supposed to work in a country that is trying to have optimal health. Outpatient care is simply the actual care that happens in various settings that are not inpatient. It can be by a specialist, which would not be primary care. Often primary care happens in outpatient care, but what about a hospitalist? If you ever get admitted to the hospital, especially if you have many problems, you might have to stay there for a while. Instead of the old-fashioned model where your primary care doc would just show up at the hospital, in fact, that's what used to happen in the 90s. I remember I worked at a answering service, and overnight, the nurses would call in from the hospital and give tags, meaning special messages that needed to be delivered to primary care docs in their community to let them know that one of their patients was admitted overnight. The doctors would call in the morning for their tags, and then they'd know which hospitals they had to round at or visit that day. Of course, we're too busy for that now, and so what happens now is the in-hospital hospitalist becomes the primary care doc while you're in the hospital. That person can interface with your outpatient primary care doc. So primary care can happen inpatient. However, most of the time it happens in outpatient settings. Primary care that is accessible in the community should take place in an outpatient care setting, obviously, because you don't want to have to get inpatient to go see the hospitalists, even though the hospitalists I know are awesome. Still, there's plenty of cool primary care people in outpatient care, and it's much easier to get there, right? But think about it. There's a lot of settings. So let's look at the different outpatient care settings and methods that we have now today in 2013. We have what we've always had, which is private practice, office-based practitioners. Well, with the rise of managed care organizations, this has really gotten routed out. And instead, you have a lot more hospital outpatient. When they started making it so inpatient stays were shorter or discouraged, the hospitals made a lot of outpatient services so that the people who would normally get these services inpatient could have it outpatient and be a little easier. For example, surgical procedures that can happen outpatient, or home health things. Like I remember in the early 90s, you would never imagine somebody going home with a bunch of health equipment and being hooked up at home. Well, now it's pretty standard. After an operation or whatever, you get sent home with a bunch of health equipment. And but then you also, in the past, have had freestanding centers. So if you think of a center that you've gone to where they get a lot done with you, they can do rehab, maybe dental, or maybe a center that does retail health. Those different centers offering outpatient services, that's kind of new too. We're really hoping to see a lot more mobile services. So think about the rural areas. You just drive over there and do people's mammograms. They'd all get them done, right? And even though I live in the city of Boston, I live very near hospitals. But I'm just thinking that it would be so much easier if the hospital came to me if I was having problems and I didn't really need to be admitted or go to the ER. I worked for the Army, and in the Army, you can imagine what kind of things they develop for mobile health. I mean, they're on the battlefield. They need to hurry up to these soldiers and get them fixed. A lot of that technology can be just transferred to our U.S. healthcare system. It's already developed, and we can go around to people even in the inner cities where there's density, but maybe people can't get out. Imagine a mom who's got a bunch of little kids. How is she going to get to a clinic to do a mammogram, right? I really see a lot of future for mobile. I hope it happens. Phone triage, it's so easy to do phone triage, yet we don't really leverage it the way we could. A great example of phone triage, I think, is these EAPs, employee assistance programs. They have a big mental health referral component. If you are on one and you call them, I encourage you to do so. They can help refer you to different services. And so phone triage can be very, very useful, and it's super cheap. We already have the technology. As I was saying, home care has increased with the decrease of inpatient services, nursing care, rehab, and it's a nice alternative to institutionalization. Here are some more outpatient care settings and methods. We have hospice care. So if a person is not really going to live that long, they might want to be put in hospice care, which is more focused on quality of life in the last days. And this also is an outpatient care setting technically because it's not inpatient. You have outpatient long-term care, such as adult daycare. These are very nice, especially respite care for Alzheimer's caregivers, so they can drop off their loved one at an adult daycare and make sure that person is cared for all day, and then they can go to work. Of course, my favorite, public health services. Very local, limited in scope, and they have to do with family planning and mental health. But you can come to our public health services, whatever we can scrape together on what little funding we have, and you're welcome to use our services in an outpatient setting. Of course, we have community health and free clinics trying to get people in there. There are federal grant funds starting in 1960s for these. And then finally, there's alternative medicine. There's your acupuncture, your massage, and all those outpatient settings that people are using in the U.S. So with all these different settings, you can imagine that there are certain factors that even though these settings are all different, they all have to do with non-inpatient care, right? So there's certain factors that really affect how outpatient care is delivered. Now remember, there's a lot of it now in all these different settings. So let's start with the first factor, which is reimbursement. It costs less than inpatient no matter how you calculate the cost. And if you have a quicker inpatient discharge, you're going to have more outpatient, right? And so you need all these settings. So in the past, when hospitals, remember what I discussed in Chapter 6 about retrospective versus prospective reimbursement in our history of healthcare. Well, when we started doing the prospective reimbursement, which was where you had to actually project how much your costs are going to be and make an agreement of how much things are going to cost, hospital realized that they couldn't be breaking the bank anymore with inpatient treatments, and they scrambled to set up outpatient services so they could get people out of inpatient but then still serve them. This led to a boom in home health care. And so as you can see through this, as insurance changed what they wanted to reimburse for, it changed what outpatient settings were popular. And so that can affect what sort of outpatient care is simply available. Next, there are technologic factors. One thing that's really cool about technology, although we beat on it a lot in these lectures, is that it has created less invasive surgical procedures. So therefore, you don't have to be totally cut open. You have less invasiveness, and so you can go to these ambulatory surgery centers. Also, short-acting anesthetics. You don't have to be knocked out for 2 days. Maybe you don't even need somebody to drive you home anymore, right? And so that's cool. And then less, who wants to be cut up? It's less traumatic to have those kinds of surgeries that are less invasive. There's a shorter recovery time, right? It's just way cooler. And technology allows outpatient diagnosis and treatment that was never available before. There were so many times in the past where you actually had to be hospitalized in order to get maybe certain kinds of invasive tests. Well, now these diagnostic tests, they're not as invasive. They found ways to test all kinds of stuff in our blood and our urine, and you can do that outpatient. It's just beautiful. This is the beautiful side of healthcare technology. And then, of course, in the background, you've got these utilization control factors going on. Payers are discouraging inpatient stays through reimbursement and other things. They're also doing this thing of prior authorization before admission, which is always, sort of dicey if you come in through the ER, but it's not as dicey if you are like worried about an ongoing problem you have. Like, let's say that you have an ongoing diabetes problem and you start, fainting. Then you might be able to decide, get authorized to go to the hospital if it's necessary, because if you keep fainting, maybe something serious needs to happen, right? And so in that situation, there would be some prior authorization. And of course, once you got in there, they'd monitor you. Do you really need to still be in here? Have we fixed your faintings and we can send you home? Finally, there are social factors. And cynically, when we started seeing this egress away from inpatient to outpatient, you started seeing, hospitals kicking people out. One of the themes was that women didn't have the time they really needed to go into the hospital, have a baby, and leave. They were getting kicked out early. And so that's what people were talking about. However, as time has gone on, and since that change has occurred and sort of rippled through our healthcare system, we realize now that patients actually prefer care at home and community-based settings. So even though maybe in certain circumstances people should stay in the hospital longer than they are, because you'll see newspaper articles about readmissions that shouldn't have happened, like people should have maybe stayed in longer, they were still sick and they shouldn't have gone home, and then they had to come back, like they made a mistake of letting them go home. You still have all of that going on, but in the big picture, everyone has liked the healthcare system, the insurance, and patients have liked the idea of not living inpatient and trying to get out of there and go home and do outpatient services. They have a sense of independence and control. It's just a higher quality of life. So our challenge is not that patients want to be in the hospital and we don't want them there. Our challenge is to figure out what patients really need to stay in the hospital before we let them out, and what patients really don't belong in the hospital in the first place, and do a better job of that. So let's talk currently, today, 2013, about Americans and current primary care access and services. So this is a chart of the access to primary care. So let's take this chart apart a little bit. On the left, you have the proportion or percentage of Americans. And this is all from 2009, so this is pretty recent, right? Across the x-axis, you just have a grab bag of different characteristics. So, for instance, if you're younger than 18 years old, but you're also black, you would be in the younger than 18 years old bars, or you'd be in the black bars too, right? And so this is like kind of double dipping. So you have to kind of get that hat on when you look at each set of these bars separately. Well, let's start with those who are under the age of 18 years. If you look at the yellow bar, it's a little over 5%. So what does that mean? Well, of people, the percent of Americans under 18 years old who got delayed or no medical care due to cost, okay, that's why they didn't go, that's 5%, okay? Less than 18 years old, there's only 5% of these people who are delaying or not getting medical care because of cost. That doesn't look so bad, does it? And then look at the red one. These are the percentage of those people who did not get a prescription drug due to cost, right? There's a little lower. And then you also have in the blue bar, the percentage of people who didn't get any dental, right? Now, let's just start looking at where the bars get big. If you look over 18 to 64 years old, that's a lot of people, that's a lot of adults. Boy, do those bars shoot up, right? And then when you look at 65 plus, it goes down. Well, obviously there's Medicare. So in between being a kid and being an elder, you've got a big problem, but not with prescriptions. That red bar is not much different. Okay, well, let's look at white, black, Hispanic, right? Where are the bars high? Well, they're high on white. They're too high. but they're higher in Black and Hispanic, right? And then let's look at the uninsured. This is where, or the insured, let's look at the insured first, and then the uninsured. Well, does this make any sense? That among insured people, it doesn't matter what age you are, what color you are, what ethnicity you are, or whatever, almost 10% of uninsured people were delayed or getting or didn't get medical care because of cost. They're already insured. And drugs. And no dental. And what's going on here? So you can just imagine why the uninsured is through the roof. Here's your bonus question. Why is the red bar shorter than the others, no matter where you look? Well, I'm going to tell you about something that I learned about called a patient assistance program. These are put on by pharmaceutical companies. So if you are an elder and you are diagnosed with Alzheimer's disease and you cannot pay for the drug, sometimes you can be on one of these patient assistance programs where the pharmaceutical company will donate money so you can pay for your drug. Isn't that nice? Outpatient services in the U.S. In the 2008 National Ambulatory Medical Care Survey, Americans made 960 million visits, more than 3 per person, to office-based physicians. And I just want to throw on that for DOs, that was 7.3% of the visits. So these are MDs, right? And remember the lecture on MDs and DOs. DOs tend to be general practitioners, and also they have cool stuff like acupuncture and chiropractic that MDs don't have. And so it's too bad that more people aren't going to them, but there aren't that many of them. So 91.5% of these 960 million visits took place in metropolitan areas, and it makes sense. Even though I live down the street from my clinic, when I'm there, I hear people talking about in the waiting room that they drove from the Cape, from Cape Cod, or they drove from the West, Springfield, or whatever, to come and get care here in Boston. And so that makes sense. So visits per person were higher in metropolitan areas than rural areas, maybe even if people live in the rural area. And the visits per person are higher in the Northeast, where I am, where Boston is, and lowest in the Midwest. And so there's probably a lot of geographic and other reasons for this. So overall, who are we visiting? Using the same data, we see that all others is a pretty big one. And this looks a lot like our other graph where we're looking at specialists, because you'll see the yellow, red, blue, and green are all generalists, right? And so that's who we're visiting. We're mostly going to specialists, right? I mean, if you look at it, 60% of our visits are to some sort of generalist, but it does seem like if 80% of our problems or 90% of our problems really belong in primary care, that this 39% doesn't look right. And where are we visiting them? Well, it's kind of interesting to see that in the Midwest, where health is actually pretty good, that there are fewer visits. And in the South, where health is on average worse, and I'm talking about metrics where you look at the southern states versus the northern states or the western states, etc., you have a lot of visits. And as you can see, if there's more specialists, those visits might be to specialists, and if those specialists are giving unwarranted care, that can actually hurt people. Obviously, if you have an operation you shouldn't have had, then you're going to be sicker. And so who knows if this is what the implications of this phenomenon actually is. So that leads us to other issues in primary care that haven't been talked about that we have to go over, right? Because community-oriented primary care is something that, it's kind of a great concept, but isn't really happening. In 1978, we're all hippies in the 70s, we're thinking liberally about people having control over their health care, right? This international conference on primary health care, they were really thinking about this. They said, do people have personal ownership of their health outcomes? Because when you feel like you can affect your own health, you're just healthier, right? If you feel like beaten down that you're in some sort of system that you can be healthy if the system works, you don't really have self-efficacy and your health outcomes are not as good. So this really requires a partnership between clinicians and patients, a very sort of stereotypical story is in the early 80s, my dad was diagnosed with Crohn's disease, and Crohn's disease was very rare then. Nobody knew much about it. Well, sure enough, he went down the street to the private practice and he started seeing Dr. So-and-so, internal medicine doc. And this guy just teamed up with my dad. My dad's an engineer. He started reading all the medical literature. He'd bring things into his doctor and say, maybe this will help me. Maybe fish oil will help me. Maybe prednisone will help me. And boy, that doctor would partner with him and try different things. And he loves that doctor. If it wasn't that doctor, my dad wouldn't be like in his 70s playing tennis, right? Like, he's a Crohn's patient. Can you believe it? But that's the way it was supposed to work, and now it's really hard to get that going, right? Because it's really hard to partner with your primary care doc. Just there's so much noise. And so community-oriented primary care is primary care plus. It's primary care plus concern for the population, remember, essential health, as well as the individual. And it's broader than strict encounter-based activities. My dad's relationship with his internal medicine doc was about my dad's life. It wasn't about Crohn's disease. Can my dad play tennis? How can we make it so my dad can have Crohn's disease and plays tennis? I can't even tell you how much that was a part of the discussion between him and his doctor. Emotional and spiritual well-being. And in 1978, we were worried about this, and look at the year. Just like we have primary care, secondary care, and tertiary care, we got primary prevention, secondary prevention, and tertiary prevention. That's where I work, in public health and prevention lab. Primary prevention is our favorite. That's where it doesn't happen in the first place. You don't get diabetes. You don't get cardiovascular disease. But secondary prevention is, whoa, you got it? Let's mitigate it. It's preventing existing conditions from getting worse. It's not a charge for really primary care, right? Primary care is really supposed to be about getting you to the right people, to the right treatments, the right diagnosis, and just air traffic controlling your whole health care. But studies show that secondary prevention can be positively affected by good primary care. Because think about it. If you are found to have diabetes and then you're referred to a diabetologist by your primary care doc, and they're keeping track of you through that diabetologist, the secondary prevention of not getting eye problems or foot problems or the other things that can come with diabetes is better handled because you've got your primary care doc or nurse at the helm and is sort of driving this, connecting you with your secondary care. So your secondary prevention gets better. Also, disease management gets better. This is a really nice slide because it shows a really great example. You've got common conditions, which are red over here, and uncommon conditions, which are blue over here. So common conditions are like ear infections. A lot of people get them. And then uncommon conditions, thank goodness, are like ovarian cancer. Unfortunately, too many people get that, but luckily not nearly as many as get ear infections. If you got ovarian cancer, you better be at a specialist, okay? Because it's going to be way better treatment than a generalist. If you got an ear infection, obviously a generalist is going to be better at it because they see ear infections every day. But let's say you've got a migraine. That's a toss-up, right? Because migraines in the realm of neurology. A lot of people with migraines are seen in primary care and their migraines are managed pretty well. Would you think that seeing a specialist for migraines just off the bat would give you better care? You would think it would. But actually, for something that's purple in the middle, generalists are better than specialists. So there are conditions that are seen in primary care and specialty care clinics, and ongoing care from the actual general practitioner becomes better. And how you can envision this is imagine a person with migraines who's managed nicely under their primary care, but suddenly they have a complication. They're not going to be managed in specialty care long term because they're not good at managing people in specialty care long term. They're good at episodic care. So you take a turn for a worse, they work on you a little bit, they work with your primary care doc, and you're bumped back to primary care until some other migraine thing happens to you. That's why it's better to just have you under the care of the generalist than the specialist. Because as you go on going in your migraine land through the specialist, most of the time, nothing exciting's happened. Most of the time, you're not taking a turn for the worse, and it's just more expensive to be getting your meds over there and visiting them and everything. So let's talk about hospitalizations and ER care. We want those to go down. We want them to happen only when they're necessary. So poor primary care resources result in higher rates of hospitalization that could be prevented. So you see that green arrow that's pointing up, that is a pressure to cause costs for hospitalizations and ER care, and that pressure is poor primary care resources, either ones that are, people who are overstaffed in primary care can't do a good job, so you have the resources but they don't work right, or you just don't have them and people are going around them. And see how you can just drive up costs by simply not having that gate there and having everybody be able to get through it. On the other hand, studies have shown, as you can see the arrow on the left side that's pointing downward, that kids with good primary care have an involved PCP and they don't have to go to the ER as much. They get preventive services, and so stuff is prevented and they just don't use the hospital and the emergency room as much. So how can primary care lower overall cost of healthcare altogether? Well, let's look at the opinions from 4 different parts of the slide. We have this elder here who says that more primary care doctors per person lowers overall cost of healthcare for elders in the U.S. in metro areas, both inpatient and outpatient. So if our elders in the metro areas, this is a result of research where they did the study in the metro areas, if here in Boston our elders could just go to the primary care doc they need anytime they want, we would quickly reduce the cost in Boston of inpatient and outpatient care. Now let's look at the whole U.S., our entire population, not just elders, because this relationship has been shown through our whole population. For example, let's say you take a state and you count how many people are in it, right? And you put that at the bottom of your ratio. You count how many primary care practitioners are in it, and you put that at the top of your ratio, right? And you make that for all 50 states, and you sort it in order, right? The ones with the higher PCP to person ratio have the lower overall healthcare costs, the lower emergency room costs, the lower, it's just like beautiful how it works, right? Here we have this person from France. This person from France reminds us that this relationship has been demonstrated in other industrialized countries. That higher PCP to person ratio and the lower overall healthcare costs, you can replicate the little study I just described of states with countries in Europe that do this, and you'll see relationships there. Also, let's go talk to our caregivers. Care for common illnesses is more expensive if given by specialists versus generalists. Remember the migraines? I go to the neurologist, costs more. Go to the primary care doc, doesn't. And health outcomes are the same, or in some cases, as I was showing in the last slide, depending on the study that you do, sometimes they're actually better with the generalist. So here's what the effect of PCP supply is on health. If you have high rates of PCPs, like on the right side of the slide, you have just higher rates of better health. So you ask everybody, how's your health? Good, bad, poor? A greater percentage of people say good. Also, when you have a lot of PCPs, you have fewer low birth weight babies, and remember, really tiny babies, they die quicker, so that's infant mortality stuff. And you get better outcomes and access for children, right? What happens if you don't have any PCPs, right? Or you just have way fewer? Then when you go interview people, they tell you that the greater proportion of them tell you they have poor health. There's some palpable examples from studies, like there's a greater risk of uncontrolled hypertension in men. One study showed that. And another study, which I put this little blotchy thing next to, the moral hazard blotchy deal, which is the diagnosis of colorectal cancer is delayed when there's not enough PCPs. And the reason why I thought that was kind of interesting is because normally if you are going to get diagnosed with colorectal cancer, you have to have a colonoscopy, and that's kind of a specialty thing, right? Primary care sends you for it, but the primary care doc's often not going to do the colonoscopy. And so why is it that colorectal cancer would be delayed from not going to a primary care doc? Because that's specialty cancer. And so if you think you have something wrong with your colon and you just run over to the colon doctor, shouldn't you get diagnosed right away and treatment? Well, this is what happens here's a little moral hazard. A lower supply of specialists enhances the likelihood that the PCPs will screen their patients for cancers. So what ends up happening is, if you don't go to your PCP, you actually wait until you have symptoms to go to the colorectal cancer doc, and then you get diagnosed at a later stage. Whereas if you go to your PCP, they tell you to go get a colonoscopy even though nothing's going on. And then if something is going on that you don't know about because you don't have symptoms, they catch it right away. So that's why, even when it comes to sort of specialty diseases, you want them diagnosed in primary care because they are better at doing it quicker and doesn't delay the diagnosis, which is really, time is of the essence in things like cancer. So let's talk about M&Ms. I love M&Ms, right? Because I'm a public health person and I study them. Morbidity and mortality. Another way of saying it is sickness and death. So ecologic studies show an association between higher PCP to individual ratio and lower M&M. So what's an ecologic study? It's what I just described, where you go and you look at the rates of different things in different places and you go, oh, they're higher here and they're lower there. But it's hard for you to say why, right? Like we said, oh, this PCP to individual ratio, when it's high, then we have good, high health indicators. The problem is that could be just a coincidence, right? Because if you go into places where that they're like, well, especially if you look through time, this is what was given in my statistics class, you'll see that the Dow Jones has gone up over the years, and you've also seen that onion purchases have gone up over the years. Do you think onions cause the Dow Jones to go up or vice versa? Well, we don't know that there's a causal relationship between the PCP and the individual ratio and people's health statuses. It's just uncanny that it works out perfectly no matter what country you do this to, right? And so it looks like there's something connected. So I'm sitting here going, are you serious? Simply just hiring a ton more people in my city of Boston who are family practitioners, is that really going to affect my life expectancy, my stroke, my postnatal, and total mortality of at least my population? The answer is yeah. Time series studies. So what's a time series study? That's where you look at 1980, then 1990, then 2000, it's over the time. Same place, studied over time. Time series studies show this association too, so that it's more than this ecologic thing. It's also over time. When stuff goes up, PCP ratio goes up, then health goes up. When it goes down, it goes down. So it is kind of freaky how these two things track, right? So even though it's hard to show causal association, it's pretty uncanny how well M&M and the PCP to individual ratio are connected. So this has not been lost on all kinds of physicians and clinicians and public health people, and we're all trying to figure out, well, how do we then, if we believe there's some sort of causal relationship in there, how do we upregulate the good stuff, right? How do we make it so there's more PCPs if we really think that that's going to solve health problems at a global level? Or how do we at least make primary care work better for that? So in 2006, the American College of Physicians recommended a new model for primary care. So they use the term advanced medical home, and it is covered in the book. I personally had not heard of it, and I've never seen it. And I think this is more something that was a model that was tested in an environment, but I have some trouble imagining how you could roll this out. So they did this study of advanced medical home practices. In those practices, providing patient-centered care is based on a chronic care model. And chronic care means simply throughout your life, right? And so even if you don't have a chronic disease yet, most people get one, you're always getting patient-centered care. It's using evidence-based guidelines. So in other words, people like me who are epidemiologists work with clinicians, others, to make guidelines about when you should give a drug or when you should send somebody for a biopsy, things like that. And so often nobody notices we made those guidelines and they're just doing whatever they want. And so the advanced medical home helps these PCPs who are busy treating patients and not reading research always be applying these evidence-based guidelines as they change and we find more stuff out. And that can be helped by applying appropriate health information technology. Obviously, we can program that kind of stuff into the EMRs and stuff to help the PCPs remember. And the advanced medical home also requires that you demonstrate best practices. So if it's found that this is the best way to handle migraines and follow them, that everybody's doing it. And in the advanced medical home, the goal is to consistently and reliably meet the needs of patients, right? And so those needs have to be sort of measured all the time and making sure that they're being met. And at the end of the day, the advanced medical home practices include being accountable for the quality and value of the care provided. Remember the accountability seesaw. That's pretty heavy on the provider side. So the million-dollar question is, can our current U.S. healthcare system do all of the above the way it is? Could we even, using our existing primary care infrastructure, implement this advanced medical home? Do we know what our best practices are? Do we have enough evidence-based guidelines? Do we have the appropriate health information technology? Do we know how to apply it? I really wonder. So this medical home approach, one doctor is deemed as a personal physician as primary and continual medical contact, which is what we've been trying to do forever and still not doing it, but it still seems like a good idea, so here it is in the medical home. This doctor coordinates a directed team of caregivers across the healthcare system to wholly care for the patient. And it has been, like I said earlier, implemented in a small scale, and studies show it improves patient health and satisfaction, care quality, reduction in medical errors. There are cost savings without worse health outcomes. There's so much, fat to trim from our healthcare system. It's reasonable you could get cost savings without worse health outcomes. And the key to why this works is really chronic disease care. Because if you're checking in with people who have chronic diseases, even migraines, and making sure that everything is going well, it's going to cost less. So now we've reached the conclusion. Primary care is conceptually related to outpatient care. There are many outpatient settings where primary care can be delivered, but they are actually materially different concepts, and so you have to make sure you can tell them apart. Using a primary care approach, so that's more of a model, on a population by way of such as the advanced medical home, that can reduce costs while keeping quality steady. I hope you've gotten out of all the different research I've reported and everything that at the end of the day, just making sure your primary care infrastructure is healthy and able to do what it's supposed to do can really reduce costs, your healthcare costs, and really improve everybody's health outcomes. So increasing access to primary care by way of increasing outpatient services that provide primary care can improve the population health and decrease M&M. And too many specialists and not enough PCPs reduces the chances that the domains of primary care will play out, like how can you coordinate, how can you refer and all that if you don't have enough PCPs to do it. Even though all these outpatient services are available, if they're all specialty services, then what are we going to do here, right? So now that we've reached the end of this lecture, you should be able to give an example of a health outcome which is improved in a population with good access to primary care. Should be able to name and describe one of the domains of primary care. You should be able to describe one outpatient setting, and in that setting, one way primary care can be delivered. And finally, name one subpopulation in the U.S. which currently has reduced access to primary care, and say why.
As you can see, outpatient services and primary care are delivered in a multitude of settings. Think of yourself in these outpatient settings. Could you be a provider? Would you be a patient? If you can't see yourself in the outpatient primary care setting, then get ready for Chapter 8, Hospitals.